Dr. Triozzi is a professor in the Lerner School of Medicine at Case Western Reserve University and in the Department of Solid Tumor, Oncology, and Hematologic Malignancies and Blood Disorders at the Cleveland Clinic Taussig Cancer Center. He received his MD degree from Duke University and continued on in his residency and hematology oncology training at Duke. He's a long-standing researcher and clinician with over 72 peer-reviewed papers. I first met Dr. Triozzi about 18 years ago while I was interviewing for my first job. This was at OSU, Ohio State University. And I remember a vibrant, exciting oncologist and researcher interested in immune modulation to fight melanoma. His enthusiasm and personality remains as vibrant as ever, and his scientific interests are also superb. So I'm really pleased that he could take the time out and speak today. Please welcome Dr. Pierre Triozzi.
Yeah. Thank you. Oh, I'm at the Cleveland Clinic, and I'm going to get in trouble because my Cleveland Clinic insignia is down low in the left-hand corner. You can't see it. All right.
This is the green. This is it.
Very good. Yeah. It's there if anyone's checking on me. All right. I'm going to talk about melanoma clinical trials that we have at the clinic. And Dr. Crum's given us a good introduction. Several types of trials. Where's the green thing? This is the...
It's on the very first one.
Oh.
Top. Right, very top. Yeah.
Okay. Several types of clinical trials. We have phase 1 trials, phase 2 trials, and phase 3 trials. Now, phase 1 trial is when we're just getting started out, and the goal is to figure out what the right dose to give. So most of it, the focus is making sure the dose is safe, but also making sure that it does something. So that's what a phase 1 trial is. Phase 2 trials, we try to figure out, get some assessment on how well it works. How many tumors can we shrink? How many people respond? But also get some idea about the side effects. And a phase 3 trial is when we see something that looks promising in the phase 2, we do a trial and compare it to what we have to see if it's better, see if it's worth pursuing, see if it makes an impact. So those are the types of trial. And Dr. Crum talked about the... Oops.
If you push this, it blinds.
Oh, okay, all right.
The advancements on either side.
On each side. Right. So Dr. Crum talked about the staging, and most of these studies we have are for stage 3 and 4, but most of these studies on this for stage 3, what's the treatment of choice of stage 3? You cut the thing out. Patients in these studies, if you have a stage 3 melanoma, you can't cut out, that you can get on one of these studies here, but most are for stage 4 cancer that's melanoma that's spread. And there are different types, and you've heard some of this. We have immune treatments, try to boost the immune system to kill the cancer. We have what we call biochemotherapy, and that's where we take something and boost the immune system, but also give a chemotherapy, try to use the actions of both of those types of things. And Dr. Crum talked about targeted. The idea is not to kill or poison the cancer, but try to deprive it of something it needs to grow. And those are the types of trials we have. We have several drugs here, and I'll just briefly go through some of these things. We have a drug called stibogluconate, and this is a drug that induces interleukin-2. You know, interleukin-2, as Dr. Crum said, we use that to treat melanoma. This is a drug, instead of giving someone interleukin-2, this is have your body make its own interleukin-2 to fight the melanoma. We have a couple trials that use this new drug called stibogluconate. Then we have this drug here called BB111, which actually is a virus that infects and kills the blood vessels that are in the tumor. We have a drug just has a number now. It's one of those BRAF inhibitors that you've heard about, a targeted agent. And then we have this more traditional kind of biochemotherapy, kind of a particular interest of mine. You know, melanoma can start anywhere in the body. This is melanoma that starts in the eye, which looks a little different, and the approach is a little different. We have a study on that. We also have a targeted agent that targets an enzyme called PARP, and what this doesn't do a whole lot by itself, but it makes the tumor more sensitive to chemotherapies that try to kill the cancer. And then we have a couple of drugs we're studying. These are both drugs that are in common use for other cancers. What they do, they inhibit tumor blood vessels, and this is a study we have ongoing. Then we have another virus called Imcodex that kills tumors and induces an immune response. And we're comparing that to that GMCSF that was on the last slide Dr. Crum presented. And then we have another one of these new TKIs, a lot of tyrosine kinases. They have a lot of interest in these types. These drugs have made a big impact on other cancers, they need to make a big impact in melanoma. So that's the focus on some of the studies we have ongoing on the clinic. And how do you find out? You know what you do. You go to the website, clevelandclinic.org, or you can call us up, 1-866, that's toll free, isn't it? So call us up, and you'll find out what's going on. A lot of these studies, you know, you go on, and some of them are on hold because we're looking at patient side effects. Some of them we met some criteria to, you know, we have to go back to the institutional review board. So not all these studies are actively accruing. Fortunately, for some of the studies, we have pretty long waiting lists too. So you can get some of the information up, probably best by calling. I want to go back to and just highlight just a couple studies on our list here that are that may be of interest to you. And I want to talk about viruses that we're using to treat melanoma. You get a virus. What do? A little chicken soup. You rub a little something on. You get better. You know, why can't we turn melanoma into the common cold? And a lot of people are working on this, including myself. I take care of patients with melanoma, but I also take care of mice with melanoma. And we do a lot of work with viruses trying to boost the immune system. And this is a study one we've done. And you can see this top line, you give melanoma to the mice, and it actually grows pretty quick. In 30 days, you get a pretty big tumor. Of course, 30 days for a mouse is like, 5% of its lifetime. So if you just give the tumor alone, tumor grows pretty quick. You put a virus in the tumor, it grows a little slower. You rub this activator on the tumor, it grows a little slower. But if you put the two together, you inject the virus into the tumor and you rub a little activator on the tumor, you don't get any tumors at all, or some of you do, they actually go along. See that white spot on that mouse right there? That's where we put the tumor. And not only the tumor went away, but all the pigment in the area. There's a big smile on that mouse. So why can't we do this? We're doing clinical trials of these types of approach. There's a drug called Imcodex. It's a drug that I did not develop. Actually, I should have put this up. The company's called Biobex, and they have a website too that you can learn a little bit more about. I'll talk a little about it. It's a herpes virus. Herpes virus causes some bad diseases, but this virus has been attenuated, it's been modified so it doesn't cause any disease. It's also been modified so that they put this drug, GMCSF, into the virus. Again, that's a drug that's being tested in that ECOG study Dr. Crum talked about. And what this virus does, it infects tumor cells, lyses them, tumors just explode. But because of the GMCSF, it attracts immune cells. It kind of acts like a vaccine. That's what herpes viruses look like on the side there. And what happens then, this virus has been attenuated. Infects, if it gets to a normal cell, it goes in, but because it doesn't have all these enzymes that it needs, it doesn't do much in it. In a healthy cell, just kind of, virus gets in there and nothing happens on it. But if it gets in a tumor cell, it starts growing in the tumor cell. And that's the difference between the normal and tumor cells. In fact, tumor cells revved up a lot of enzymes, a lot of factors that are going to make it want it to grow, and that's what this virus exploits. It takes advantage of the stuff that makes the tumor want to grow, make it grow itself, and the tumor just explodes. All the virus is released, and what happens is that you get more tumors infected, but at the same time, this GMCSF is being released, and that attracts immune cells that create kind of a vaccine response that permeates the entire body. So we have Oncobex. It's a randomized trial where we give this virus into the tumor in it's actually more than half the people. But in the other half of the people, they get the drug itself, the GMCSF, and that's given under the skin. And you say, but I want the virus. Be careful what you wish for, because the GMCSF under skin looks like it has some activity in stage 4 melanoma. And so that's why it's incorporated in this study and also incorporated in other studies. So it's a randomized study to see if the virus plus which has the GMCSF in it, is any better than just giving GMCSF under the skin. And we're doing this study, and the goal of this is to see the response rate, see how many people get the virus versus how many people get the GMCSF respond, but also we're looking at the safety and see how long people live who get this virus. To get on the study, you have to have measurable disease. And measurable disease is pretty much a criterion for almost all studies. we want to see cancer because we want to see it getting better. We have to have some assessment that's doing something. So you have to have measurable disease. To get on this study, though, you have to have a melanoma tumor that we can actually stick a needle in. And that usually means something bigger than a centimeter by a ½ inch, but something easy. We can't stick needles in lungs, brains, livers, and stuff. It mainly confined if you have something on your skin or a lymph node, something we can feel, we can do that injection. The other thing, too, we want to make sure you're going to be able to tolerate it, and you have to have a good performance status. It means you have to be feeling pretty well before you can get this. And we want to make sure it doesn't damage you, so we do a lot of blood tests to make sure your organ function is good. If you have tumor in your brain, you can't get on it unless you have very minimal tumors. And part of this is we want to make sure you're in good shape. But the other thing is we're not quite sure how well immune things work in the brain. So if people that have active tumors in the brain, we're not sure many of these cells or things actually get up in the brain. So that's why that's an exclusion criteria. Bone metastases in melanoma usually is pretty advanced disease, but it's also kind of hard to see if it's getting better or not. So that'll exclude you. And we want to make sure this has a chance of working. If you have a lot of cancer, your immune system's already down, and we want this. If there's not going to be anything there we can stimulate, we don't want you to waste your time on the study. So we don't want you to have cancer everywhere. We want a fairly limited patient. And LDH is a blood test that kind of gives us assessment how much cancer you have. So if you have a real high LDH, we don't think this is a good idea. We think there's probably better things out there for you. And the way it happens, you come here to the clinic, you got something I can see or inject, I'll stick a needle in it. I do it every other week. Try to stick a needle in anything I can see or get to, and do that as long as it seems working for up to a year. If you get on the GMCSF portion of it, you get the shot. We teach you how to give it. You take it at home. You take it once a day for 2 weeks, then you take a couple of weeks off. You do that back and forth. We usually, for most immune therapies, and this is why we have all these criteria in terms of how much cancer you have, the immune system takes time to activate. You just don't give something, then you have an active immune system. It takes time. It can take months. So on this study, we try to keep you on at least for 24 weeks to give it a chance to work. So it's a little different than some chemotherapy studies where you get the drug. If it doesn't work, you're off the study. And this one, we try to keep you on to give it a chance to work. We'll move on to something else. You know what this is? This is a melanoma tumor in which the blood vessels in the tumor were highlighted. You can see that melanoma is almost all of it, about half it looks like it's blood vessels. It's a very vascular tumor. If you get a smile, we think that's really important for progress. You get a tumor, to grow, it needs blood vessels. It gets bigger, more blood vessels, and actually much of the mass of a melanoma is going to be blood vessels. So the approach would be, if you could disintegrate those blood vessels, you could deprive the ability of the melanoma to grow. And we have two approaches. Again, I mentioned one of these studies is a couple drugs. One's an IV, one's a pill called bevacizumab that we're using to try to kill the blood vessels going to the tumor. But the other thing we have is a virus that does this. And this virus is called VB111. And it's an adenovirus. An adenovirus is called, everyone in this room has an adenovirus. It's in your mucous membranes that causes symptoms related to a cold. But what was done with this adenovirus is that it was modified so it doesn't grow in anything else other than blood vessels that are growing. There's a particular target. Every young blood vessel has this, and when the virus sees this, it will grow. And when it grows in the blood vessel, it kills the blood vessel. And we have a study. It's a phase 1 trial, and this is try to figure out what the best dose of this virus is. And as opposed to other studies, this is really a safety study because this type of virus has not been tested. And our other objective, we want to see where this virus goes. We're doing blood tests, urine tests, a whole bunch of stuff. We also want to see if it works. We're making sure that the tumors can shrink. We're testing what we call biomarkers. We think we have some ideas how to do a blood test to tell us if blood vessels are being killed, and that's what we're using in this study here. And to get on this, you have to have metastatic or stage 4 melanoma. I also like if you have tumor that I can stick a needle in because I want to see if the virus actually gets into the tumor. So that's one of the criteria in the study. Again, we want to make sure you can tolerate it, good performance status. Because this thing affects blood vessels and there's maybe a risk of bleeding, we want to make sure you have a good coagulation system. That's tested by doing blood tests. Adenoviruses like to go to the liver, and they like to damage the liver, so we want to make sure your liver's in pretty good shape too before we give you this virus. As opposed to that first virus where we're injecting it right in the tumor, this virus goes in your bloodstream and goes to every tumor in your body, every blood vessel that's in the tumor in your body. So it's more of a systemic approach. You can't get on this if you have had a heart attack or something, because that's the other thing that makes new blood vessels is, if you have a cardiac event. So we don't want to have anyone that's had a cardiac event within the year. We don't want anyone to have vascular disease. If your blood vessels are bad to begin with, we don't want you to on this study just because of side effects. And in blood vessels, and a lot of blood vessels in your eye too, so we don't want any damage to your eye before we give it. That's what the retinopathy is. This adenovirus can damage the liver, so the liver has to be in good shape if you have any liver disease, no matter what it is. And brain metastasis, again, we don't think the virus gets up into the brain. We don't think, we think you're probably wasting your time with something like this because it's not going to get up in the brain. There's also a potential of more side effects, some swelling in the brain with these types of things. So it's more of a safety concern about this study. It's a one-day infusion. You come in, you get your infusion, and it either works or it doesn't. And we find that out in a month and 2 months. We check you at 1 month. If it looks like you're right, we'll check in 2 months. But after 2 months, it's either going to work or not. So it's a kind of a one-shot deal as opposed to many other treatments where protracted over several months or years. Again, clevelandclinic.org. There's our phone number. There's where I work. Sun always shines on the toxic cancer student.